Piriformis Syndrome, the second, November 11th, 2024. So, in the second part, I'm gonna reiterate some information that we already know, including that the fact Piriformis Syndrome is a neuromuscular condition resulting from the sciatic nerve getting compressed by the piriformis muscle, which can result from inflammatory condition, tumor, or other things that basically causes enlargement of the piriformis muscle and then compresses on the sciatic nerve. And the piriformis muscle functions to laterally or externally rotate the hip, also to abduct the hip, and when it is under a significant flexion, when the hip is flexed beyond 90 degrees, it starts to function as medial rotator of the hip as well, an internal rotator. It also functions to extend the hip. The piriformis muscle is also a hip extensor. Telltale sign that points to the presence of Piriformis syndrome is a buttocks pain accompanied by truncated sciatica, that is sciatic pain that is not intact throughout the leg. Sciatic pain usually radiates down the leg throughout its entire length, but when its distribution is patchy or interrupted, let's say the pain is in the buttocks, and then the sciatic pain is felt again at the posterior aspect of the knee, but not the thigh. That means there is a disjointed distribution, not an intact radiation of pain. There's an area of pain, further down, no pain, further down, pain again. That's what truncated sciatica is. And this pain is exacerbated by certain postures and also activities. These manifestations is a telltale sign of the Piriformis syndrome being present. The physical tests you can do include Freiberg test, Pace and Nagle's test, Fair test, Fishman Fair test, Beatty's test, and some novel tests that is described here include PAMR test, Sensitized Lasegue, HFD. HFD is hand floor distance test, and HCLK or heel contralateral knee test. By combining these tests, you increase theoretically the specificity and sensitivity of these tests. You can also perform deep palpation of the Piriformis syndrome in a certain area that we will explore a little bit later. But it is usually performed at the end of the examination to prevent the examiner from experiencing a confirmatory bias where you do something and you just preoccupied with the diagnosis, this has to be Piriformis syndrome. Therefore, you check the deep palpation first and you end up trying to mentally argue your way to confirm to yourself that no, this has to be a Piriformis syndrome. That is what's called confirmatory bias. And then after that, when you perform all the tests above that I've mentioned, like Freiberg test and etc., once you're preoccupied that there's a Piriformis syndrome, you will tend to bias your result to being positive. That's a confirmation bias that is something that we're trying to avoid. That's why deep palpation is performed at the last, preferably. Periclinical approach, meaning approach that doesn't involve history taking and examination as the majority of information source. In this case is imaging or other modalities of diagnostic workup such as electromyography. It doesn't have a lot of place in diagnosing the Piriformis syndrome itself since it's neither specific nor sensitive. But there has been reports of some allegedly pathognomonic features, but it is unvalidated currently. As we've mentioned, Piriformis syndrome is a neuromuscular condition where the sciatic nerve gets compressed by the piriformis muscle. The causes may include inflammation, a lesion that enlarges the piriformis muscle, such as tumor, malformation, or as a result of trauma that produces bleeding or contusion, enlarging the muscle, impinging on the sciatic nerve. The piriformis muscle itself is actually a pair of triangular muscle, the base of which inserts into the ventral part of the sacrum, so the anterior, the front part of the sacrum bone, at the level of the second and third sacroforamen. This muscle runs diagonally downward toward the greater trochanter of the femur. This exits the pelvic cavity by sliding under the greater sciatic notch of the coxal bone, which is located just above the sacrospinal ligament. The apex of this muscle inserts into the greater trochanter, the upper edge of the greater trochanter of the femur. In the gluteal region, this muscle is located deep to the gluteus maximus and superficial to the internal obturator muscle. This diagonal trajectory of piriformis muscle divides the space above it and below it into suprapiriform canal, that is the space above it, where some structures pass through, namely the supragluteal nerves and vessels, and then also infrapiriform canal, the structures that pass through which are namely sciatic nerves, inferior gluteal nerves, and pudendal nerves. However, there are anatomical variations of these structures that go through these canals. The structures that go through the infrapiriform canal has some variation in which the tibial or fibular, the other name of fibular is peroneal branch, of the sciatic nerve actually pierces through the muscle instead of going through the infrapiriformis canal, and this is present in about 11% of the population. Another variation is that the tibial branch goes through the suprapiriform canal, so the canal above the piriform muscle instead. And the common peroneal or fibular nerve goes through the lower canal, infrapiriform canal, and this is present in 3.3%. Another one which is rarer than the two of those is where the sciatic nerve entirely pierces through the piriform muscle instead of going through either canal. The image on the left, as you can see, this is a familiar image where Gmax here is gluteus maximus muscle, GM is gluteus medius, P is piriform muscle, SN here is sciatic nerve, QF quadratus femoris muscle, GT is the greater trochanter. By the way, this is the posterior view of the right buttocks, a cadaver example. STL is the sacrotuberous ligament connecting the sacrum to the ischium tuberosity. As you can see under, if you flip back the gluteus maximus, we can see the structures underlying it, including the sciatic nerve, piriformis muscle, and we can see the canal where the nerves, the sciatic nerves, and other smaller nerves pass through. This is the infrapiriform canal. The channel directly under the piriformis muscle. As you can see, it's rather triangular, the shape of the muscle, even though we cannot see the proximal insertion because it's located in front of the sacrum bone over here. These anatomical variations contribute to a higher likelihood of experiencing Piriformis syndrome. There are also anatomical variations of the proximal insertion, so the origin or the base of the piriform muscle itself has variations. The primary one, the most common one, or the principal one, the base of the piriform muscle lies, as we have mentioned, at the front aspect of the sacrum bone, at the level of the second and third sacral foramen, as opposed to the secondary or the rarer anatomic variation, and the secondary anatomic variation happens to also increase the likelihood of Piriformis syndrome. The secondary insertion is where the base of the piriformis muscle actually inserts into the greater sciatic notch of the coxal bone instead of the sacrum. And this, naturally, since the greater sciatic notch is closer to the greater trochanter, let's say over here is the sacrum bone, as is illustrated in the next image right here. This is the illustration of the primary or principal insertion, and this is secondary insertion on the right. The first one on the left, the sacrum bone is this kite-shaped bone above the tailbone. The coccygeal bone is below it, this inverted triangle bone, and above it, the slightly inverted triangle shape that is also shaped slightly like a kite. This is the sacrum bone. This is the piriform muscle, the red band muscle. All the other muscles are turned invincible so that we can visualize the piriform muscle better. This is the piriform muscle. Under it would be the infrapiriform canal where the inferior gluteal, pudendal, and sciatic nerve passes through. The coxal bone is the axe-shaped bone right here that forms the majority of the bony part of the pelvis. This is the ilium part of the coxal bone, and then this is the ischium part, and then this is the pubis part. In the primary insertion, the piriform muscle is attached to the anterior portion of the sacrum at the level of the second and third sacroforamen, and then the distal insertion is the same between both insertion type. That is the upper edge of the greater trochanter of the femur. The difference is that in the secondary insertion, the proximal insertion of the piriform muscle is actually the greater sciatic notch of the coxal bone instead of the sacrum. And as you can see, this makes the muscle shorter. Therefore, the canals are more prone to being compressed due to not enough expanse of the piriform muscle. So there's less room for the structures to go through. And this blue line is an imaginary line that you take from the posterior spina iliaca superior, PSIS. You take an imaginary line connecting PSIS to the greater trochanter. Both are palpable, even in fat subjects, except in extremely fat ones. Even then, they are still palpable, although not as easy. You take an imaginary line between those two structures, the greater femoral trochanter of the femur and the PSIS, and then you take the middle third and then go down 1 to 2 centimeters. That will be the starting point for you to deep palpate the piriform muscle. And then throughout this trajectory, starting from that point, you might feel induration or painful cord or painful swelling if there is a piriformis muscle pathology, and that is frequent in the case of Piriformis syndrome. CFJ is the coxofemoral joint. The SIJ is the sacroiliac joint. Due to the proximity of these structures, it is also common that the conditions that involve inflammation of the coxofemoral joint or sacroiliac joint present with similar symptoms. Therefore, you should also examine and interview the patient for those conditions as well. The motor function of the piriformis muscle, as we have mentioned, include lateral rotation or external rotation of the hip. And when the hip is flexed significantly, that is beyond 90 degrees, it also functions as medial rotator of the hip or internal rotator. This will be significant once we get to discuss about the HCLK test or maneuver to test for Piriformis syndrome. Piriformis muscle also performs hip extension, and if the proximal insertion of the piriformis muscle, that is this one, this proximal insertion, proximal meaning closer to the head, so this initial insertion, if it is slightly higher, it might also perform hip abduction. In principle, to stress a muscle, if you want to stress a muscle, therefore you want to test whether there's something wrong with the muscle or not, where normally if you stress a muscle, it's not painful unless there's a pathology in there, which is what we're looking for. So if the functions of Piriformis syndrome include external hip rotation, hip extension, then you simply do or move the limb the opposite way of this. If you want to test with piriformis muscle stress, and you see this is hip extension, then you flex the hip or medially rotate the hip. Or if you want to try to flex it beyond 90 degrees first, you do the opposite of internal hip rotation. That is, you go lateral hip rotation, which we will summarize later in the examination, in the physical examination. The end or distal insertion of the piriform muscle, that is at the upper side of the retrotrochanter of the femur, its tendinous fibers are intermixed with those of gemelli muscles and gluteus medius muscles, and also internal obturator actually, and this forms a muscular nexus that all performs as hip extensor and lateral rotator. If you look at the piriformis muscle from the side, this is from the back. If you look at it from the side, it actually lies slightly to the front of the sacroiliac joint, but slightly behind the coxofemoral joint. And when the patient is seated or cross-legged, the piriformis muscle is also stretched out, and this explains why at these positions sometimes the buttocks pain is exacerbated. During prolonged sitting, especially when the torso of the patient is sagittally straight, meaning you sitting straight, if you look at the side, the torso is straight up, the pelvis is inadvertently getting an anteversion, meaning the lower part of the pelvis is tilted back and the upper part of the pelvis is tilted forward. And this causes tension in the sacrotuberous ligament and the piriform muscle. Those two are very related in terms of location, in proximity, and they both run diagonally downward. So stress in one structure can easily stress the other due to their proximity. And also, during prolonged or hyper-intense running, the lower part of the sacrum bears the load of the ground impact of the leg, and the leg then delivers this load onto the pelvis, and this causes the pelvis to also antevert. The lower part of the pelvis tilted backward and the upper part tilted forward, and this again tenses the piriform muscle and sacrotuberous ligament, causing the pain. The telltale manifestation, as we have mentioned in the key points, is a truncated sciatic pain, where sciatic pain is, instead of distributed throughout the entire length, it is distributed in interrupted zones or lengths. And this is usually exacerbated by certain positions or activities, as we have mentioned, including seated position, prolonged sitting, which is common in today's work, and also prolonged running or hyper-intense running. While you're assessing for Piriformis syndrome, you should also assess for other possible causes, including pathologies in the intervertebral discs that may cause compression and sciatica thus far, and coxofemoral joint arthritis, sacroiliac joint arthritis as well, and whether there is a trauma to the buttocks that may cause the Piriformis syndrome or other pathology that may require imaging such as MRI to exclude. You should also note what exacerbates and what relieves the pain of the patient, and things that are related to those exacerbating factors, such as if they are office worker, then sitting for prolonged periods of time after the work, they notice their buttocks pain getting worse, then that also points to Piriformis syndrome. Examination that you can do while the patient is in static position to increase your accuracy of identifying Piriformis syndrome, including pelvic positioning that is sagittally abnormal. Sagittal is something that means you are evaluating the structure from the side. If you see the pelvic is slightly anteverted or grossly anteverted, that also points to the likelihood of Piriformis syndrome happening. And also discrepant lower limb lengths. This also puts strain onto the piriform muscle. This is usually a birth defect, 1. 2, the result of a poorly treated fracture, which cause limb length discrepancy, or polio or rickets, that also can cause a lower limb length discrepancy, and hip flexion abnormality, which may point to something that is secondary or caused by the piriformis pain itself. Because as we have known that Piriformis syndrome is closely related to piriformis muscle, and the piriformis muscle is a hip extensor. So flexing the hip will tense up the piriform muscle, therefore causing hip flexion to be limited sometimes. And if you examine the patient in supine position, it may also reveal that there is an excessive external rotation of the leg, and this is a sign that the piriform muscle is contracted for overly long of a time. This may result from persistent inflammation or spasm of the piriform muscle for prolonged periods of time until it forms a contracture. If you attempt to correct this, that is by doing the opposite, which means internal rotation of the hip, this will produce the Piriformis syndrome pain. And then now we go into the deep palpation of the piriformis muscle. This can be done despite the piriformis muscle being basically buried under other thicker muscles, such as the gluteus maximus, gluteus medius. You can do this by taking an imaginary line like this between the PSIS and greater trochanter of the femur, and you take the middle third, and from that middle third you go 1 to 2 centimeters below, caudally or distally. That is the starting area for you to palpate, deep palpate for piriformis muscle pathology that may include induration, so some sort of firm swelling, and it is usually found in piriformis syndrome and is usually tender or painful to the touch. This is performed when with the patient on contralateral decubitus, meaning decubitus position, lying on their side. Contralateral meaning on the other side of the affected side. So if the painful leg is the right side, you tell the patient to lie on their left side if the painful side is their right side. With the hip flexed 45 degree and with slight internal rotation so that the knee is touching the exam table. And tests that you can do for piriformis syndrome, and these are based on the anatomy and pathophysiologic hypotheses of the piriformis syndrome. These tests are more useful if you combine it with each other because the muscle fibers of the piriformis muscle that is attached to the greater trochanter of the femur, they are actually intermixed with fibers from gemelli muscle, internal obturator muscle, and gluteus medius muscle, and it makes it hard to determine out of those three muscles which one is actually causing the pain. And these muscle nexus also intertwines automatically, naturally, the sciatic nerve that goes through the infrapiriform canal, which means it is likely that one of them can also impinge the sciatic nerve, causing the symptom. These tests are positive. In the majority of cases, they are positive when the piriform pain is elicited by the test, which include buttocks pain or sciatic tingling or numbness, which is tingling or numbness that radiates down the leg or any distribution of the leg. And usually, as we've mentioned, truncated sciatica, where the pain is distributed interruptedly along the leg instead of in one intact radiation of pain. And these tests may need to be performed for tens of seconds to elicit the symptoms. This is especially for the pace in Nagle test is usually able to induce the sciatic pain rapidly. The prolonged testing is usually for the PAMR test. This is because a lot of the other muscles sort of compensate for the stress of the piriform muscle. So the piriform muscle is stretched by the PAMR test, but then this test not only stretches the piriform muscle, it also stretches the other muscle. So they are dividing the load. So it takes longer to cause pain to the piriform muscle because the load is divided across different muscles instead of just mostly on the piriform muscle. So this is the summary. So if you'd like to have a quick summary of the test, you can look at here, and we will go to the illustration. So this is the Freiberg test. You perform it with the patient supine and their hip flexed 30 to 45 degree with their knee extended, and then you force hip abduction. So the hip is moved closer to the midline with hip internal rotation. As you can see, this foot is turned inward, but not because the foot is turned inward, but because it's the hip that's turned inward. That is the internal rotation. If you do this while the patient is supine with the hip flexed 30 to 45 degree with knee extended, and it causes the piriform pain, that's a positive test for the Freiberg test, positive result. And the fair test is when you flex the hip and knee 90 degrees, so it's perpendicular to each other, some sort of inverted L shape, and then you force hip adduction and hip internal rotation as well. And if this induces the piriform pain, it's a positive result. This is the Pace and Nagle test. The patient is seated with their legs dangling off the seat. Then you tell the patient to open their knees apart while you resist their attempt to open their knees. If this maneuver induces piriform pain, that's positive result. And this is the Beatty's test. Beatty's test is basically the position that, if you have noticed, it's the same position that you do the deep palpation of the piriform muscle. That is contralateral decubitus with their painful side above and their healthy side below, and the hip flexed and internally rotated so that the knee touches the table. But in this case, the foot is then hooked to just behind the healthy leg. And then tell the patient to reopen their leg against your resistance. Don't let them open their leg. And if this induces piriform pain, that's positive result. Fishman fair is basically a similar position, but instead of the foot staying just behind the leg anywhere, this time the foot has to stay behind the heel of the healthy side. And then tell the patient to move this foot upward along the leg. If this induces the piriform pain, that's a positive result. This is the PAMR test, the procubitus adduction medial rotation. Procubitus meaning the patient is in prone position like this, facing the floor, with the knee flexed 90 degree, perpendicular like this, so sort of an L shape, and then you force again hip adduction and hip internal rotation. So this is basically the same as fair test, but the patient is facing the floor. Fair test, you also perform hip adduction and hip internal rotation, but the patient is supine, facing the ceiling. But in this case, the patient is facing the floor. Both fair test and PAMR test have their knee and hip forming an L shape, that is flexed 90 degree. Except in the PAMR test, the hip doesn't flex 90 degree because it cannot do that because it's facing the ground. Sensitized Lasegue test. Lasegue test itself, the regular Lasegue test is one that is performed to seek out whether there is a sciatic nerve compression, sciatic nerve root compression. So it's a nerve root compression. Regular Lasegue would be positive for nerve root compression, so compression at the level of the nerve root, that is at the level of the nerve that just gets out of the spinal cord, not further down. Once it's further down, it's no longer called nerve root, it's just nerve. So how do you turn regular LASIK into something that can help you identify Piriformis syndrome? Easy. You perform maximal hip interrotation so that the foot is facing inward, and then you do the regular LASIK test after, that is, flexing the hip until it causes pain. That is the piriform pain. LASIK test itself is usually considered positive when the degree of the hip flexion is 45 degrees. And this is the sensitized hand floor distance, and it involves two positions where in each position you must measure the distance, the shortest distance between the patient's hand and the floor. The first position, basically the feet are together, facing forward, parallel, and tell the patient to reach for the floor as much as possible. And then you measure the shorter distance between the hand and the floor. And then in the second position, you do the same, but this time both hips are external rotated maximally so that the feet are facing outward. And then you tell the patient again to reach for the floor as much as possible. And then you measure the shortest distance between their hand and the floor. If you compare the two, in case of Piriformis syndrome, the distance is bigger in position 2 than in position 1. That points to a positive result for Piriformis syndrome if the distance in position 2 is greater than the distance in position 1. Heel contralateral knee is basically you tell the patient to put their foot of the painful side on the knee of the healthy side. This will force them to put their hip on external rotation, significant external rotation, in their knee flexed. And then you tell the patient to maintain this position against your pull. You try to strengthen this and tell the patient to not let you do that. You try to straighten the leg and tell the patient to not let you do that. This will induce the pain, the piriform pain, in the case of Piriformis syndrome, which will result in a positive test. And the preclinical approach to Piriformis syndrome, currently there's not many value other than to exclude the diagnosis because it's neither sensitive nor specific, and the pathognomonic value is currently still unvalidated for electromyography. And this, we get to the discussion of the information that we've gathered so far. So there has been a notion where the Piriformis syndrome is actually a rare condition. It is a rare condition because it is rarely considered by the examiner. So how are you supposed to notify or identify a disease if you don't know even that it exists, or it's not even part of your suspicion? How are you supposed to know that if you're not even thinking of it? And the clinical picture that strongly points to the presence of a Piriformis syndrome is the buttocks pain and the truncated sciatica, that is sciatic pain with patchy distribution that is exacerbated by certain positions or activities. Palpation of the piriformis muscle, you can do that, but it's usually performed at the end to avoid confirmation bias, as we have mentioned earlier. The piriformis muscle is buried under other muscles that makes it harder to specify whether the pain is actually coming from the piriformis muscle, and that's why combining these tests will theoretically increase the sensitivity and the specificity. However, it's still unvalidated, but theoretically that's how it works. Especially the Freiberg test and Fair test, where these two tests causes stretching of the piriform muscle in medial rotation, and you combine it with HCLK, for example, where it stretches it in lateral rotation. If both are positive, meaning this is very likely that it's coming from the piriform, because the muscle that is in pain if you do these three tests is the piriform muscle. Because on HCLK, the hip is extremely flexed, and if you do the lateral rotation, it will oppose the medial rotation of the piriform muscle, as you might have remembered. When the hip is flexed extremely, that is beyond 90 degrees, the piriform muscle now adopt a function of medial rotator. So if you do lateral rotation, well, you do the HCLK test, that is this test. So you do hip flexion, extreme hip flexion, and you induce medial rotation by trying to pull on it, and the patient resists your pull. Therefore, he has to, or he is then pulling his leg to stay bent like this. It will inadvertently cause lateral rotation. Therefore, it will stretch the piriform muscle that now functions as medial rotator because the hip is flexed beyond 90 degrees. That's just an example of combination test that you can do to help you specify that this is actually from the piriform muscle. That is Freiberg, FAIR test, HCLK test. You can also combine other tests if you will. And then also, for example, Pacey Nagle's and Beatty's tests. These stresses the external hip rotators while the hip is abducted. And this PAMR maneuver, this one that may be needed to be performed a little bit longer because a lot of the load is divided into other muscles. Thanks for watching.